Hello, everybody. Welcome to another IPC Partners Journal Club. I'm delighted to have Dr. James Price with us today. Just me today. Um, John is off on paternity leave. Congratulations, John. So today, James is going to talk about proactive genome sequencing for IPC. Is it worth it? I've followed James's research for the last 18 months, 2 years, and I saw James speak at the IPS conference in Brighton recently. And I personally think there's a huge amount of potential around genome sequencing, but I still feel like there is a little bit of unknown about the cost effectiveness and what it looks like on a day to day in terms of how it fits into our normal workflows and processes. So, really excited to invite James on to share his perspectives around this particular paper. Paper was published in JRHI looking at cost implications of integrating SARS-CoV-2 genome sequencing for IPC control and investigation. So we know that there's a lot of potential around genome sequencing for transmission, mapping, and outbreak detection and surveillance as well. So really interested to hear James's talk. Before I hand over to James, just a quick reminder about what we're trying to do within Journal Club. So we run these sessions every fortnight, completely free for everybody to attend. So please share them with your networks, your teams if you work in healthcare. And we'd love it if you promoted it or shared it on LinkedIn or other social media channels as well, because ultimately we're trying to build a bit of an audience to have some opportunities for discussion and try and develop some CPD opportunities as well. It really is all about you guys in the audience as well. So we've managed to host this. We're delighted that James can come on, but we'd really love to hear your own opinions, thoughts, and obviously please do use the Q&A box for any questions that you might have for James as well. Ideally, we'd like to have a little bit of fun as well, so we don't take ourselves too seriously. Just to say that we record all of our journal clubs and they're all made available online after our event on our YouTube channel. And I think that is where I'm going to stop. So I'm going to stop sharing and James, I'll hand over to you. And yeah, welcome, James, and delighted to have you on and love to hear your thoughts.
Thanks, Phil. Thanks for having me. Hi, everybody. I'm going to try and see how I share this slide. You'd think after this many years it would come very smoothly. Bear with me a sec.
That's perfect, James.
Great. I'll start. So thanks, everyone. So thanks for having me. As Phil said, I'm a clinical academic that works mainly down in Sussex in Brighton. I spent half my time working as an infection control doctor and the other half of my time looking at doing research, looking at ways that we can try and optimize IPC, particularly through using whole genome sequencing. So this area is very close to my heart, and so it's been great to at least have a read of this. I'm happy to share thoughts and also interested to hear other people's thoughts. So as Phil alluded to, so we're going to be looking at the the manuscript by Panker et al., which was published in the Journal of Hospital Infection a couple of years ago. And this is an economic evaluation that accompanied a study on hospital onset COVID infections. And this was a sequencing study for infection prevention. And I should probably say now that there's a conflict of interest that I'm a co-author on this paper and the study paper. So feel free to pick apart what I say, but I'm acknowledging that. And because someone has very recently showed me how to create QR codes, I've put one up there if anyone's interested in, if hasn't already got the paper. And the aims of this really is, I just want to set the scene of where the study was, summarize what the study did, what it found, and try and, I suppose, help unpack some health economic concepts, and then reflect on what those mean for us in IPC, and how we might apply sequencing beyond COVID. I need to put this slide up. You'll be shocked to hear I'm not a health economics expert. I'm a clinician, and so this is coming at it from a non-expert point of view, but from someone who is enthusiastic about it. So to set the scene, you'll all vividly remember this. So this study took place between October 20 and April 21, and so this was in the midst of the second wave of the pandemic. Which was dominated by the Alpha variant that we knew out at the time. Hospitals were under enormous strain, which I don't need to tell you guys about. The bed occupancy was consistently high. Our testing capacity had only recently scaled up. PPE supply and staff availability were a bit unstable. And the guidance on patient isolation and staff testing was changing rapidly. So when we talk about costs and workflows as we relate to in this paper, we're looking at the NHS that's operating under extreme conditions. And I think it's important to remember that when we come on to talk a bit about how we might generalize that into normal practice, probably the wrong terminology, but so in terms of the challenge, it was the stage of the pandemic. We all knew that nosocomial hospital-acquired infections were a serious concern. These were contributing to about 10% of COVID cases at the time, and they were associated with the excess mortality, staff sickness, bed closures. And I think it's fair to say that our traditional IPC approaches, where we're using epidemiology, symptom tracing, and timelines, were struggling to separate true hospital-acquired infection from community onset infections. And that's because, as we very well know, COVID behaves differently to many other healthcare-associated infections. There's the long and variable incubation period, there's the pre-symptomatic, asymptomatic transmission, and that symptoms alone arguably weren't as reliable as a marker of infectionness. And all of this made our kind of standard definitions of infection onset greater than 7 days after admission problematic. And so I'll leave that there because we'll come on to talk about that. But the proposed solution for this piece of work was around whole genome sequencing of COVID, of SARS-CoV-2, offering an opportunity to resolve some of these uncertainties so that by comparing viral sequences, at high resolution, IPC teams could see whether cases were genetically linked and essentially trying to confirm or refute whether hospital transmissions were taking place. But the challenge, however, was around turnaround time. Sequences we knew were available through, and you'll remember the COG UK consortium where we were sending our isolates to, but we weren't getting routine feedback into hospitals fast enough to help us action IPC changes. So a hospital onset COVID infection study was designed to test whether if we did some rapid sequencing and got the results back in time, there would be some meaningful output. And so this was, the project was as much about implementation as about technology itself, and could sequencing realistically be put into the IPC workflow? So where the study we're going to talk about today sits in is that it was, we need to put it in place with the Hokie paper, the clinical paper. So I need to talk about both of them. But whilst the clinical paper was reporting on the clinical and operational results, the paper we'll discuss today address more of the economic question. If we integrate whole genome sequencing into IPC practice, what does it cost the hospital and what might it save in terms of money overall? So we weren't looking, and it wasn't looking specifically at the cost effectiveness in terms of quality adjusted life years or mortality, which we'll come on to talk about, which would require a much more broad set of data. This was about hospital level costing and the direct cost of sequencing. So, as I alluded to put the health economic study in context, it's really important that we have a clear idea of what the study was built on. So I'm going to very briefly just touch on the Hokie, the hospital onset COVID infection study, which was a large scale real world implementation experiment. And I had the privilege of being involved in this in my previous role at Imperial. And the actual study looked at asking the pragmatic question in hospitals, or if hospitals had access to rapid sequencing for COVID, can this meaningfully improve infection prevention and control decisions? And it was about proving that it wasn't about proving that sequencing works, because we already knew that genomics could distinguish viruses and viral lineages, but it was about whether we could do so quickly enough that it would work, that fits in with everyday IPC practices. So this was prospective. It covered 14 different centres across the country. It was non-randomised, and it was a step design so that every site acted as its own control and cycled through 3 phases. You had a baseline phase where no sequencing was being reported. You had a rapid phase where sequencing reports were aimed to get back within 48 hours. And then there was a longer phase, which the reports came back over 5 to 10 days. And so by comparing these different phases, the researchers could see whether the introduction of genomics changed outbreak management, case definitions, and nosocomial infections. And important to recognise at the time that we were using definitions of Hokie that were based on the NHS England's criteria of positive cases after 48 hours. Now, clearly, that was what was used at the time. It's clearly imperfect because of the long incubation periods and the pre-symptomatic transmission, but that was what was being used at the time. And one of the key innovative aspects about this project was the sequencing report tool. This was an automated summary of the basic epidemiological data and the genomic relationships of isolates. And there was some color coding flagging to show that transmission clusters might have been occurring and how to support interpretation. And so the idea was to make a complex genomic information usable to busy clinical staff. And you didn't have to be a bioinformatician to have a dashboard, but this was about a clear decision support tool. And what did they find? Well, the challenge was the rapid phase, aiming within 48 hours, actually only occurred in about 9% of the patients. The average turnaround, the median turnaround time was 5 days. And in the longer phase was about 13 days. So in truth, the intervention was semi-rapid, probably at best. And the delay reflected real world bottlenecks. These were transport delay or sample transports. This is data transfer, and this was local interpretation capacity. But over 2,000 cases of hospital onset infection, what we found is that the incidence of nosocomial COVID did not change between the baseline and the intubation phases. And this was likely because the turnaround times are slower than we anticipated. But IPC decision-making did change. Sequencing led to management changes in about 8 to 10% of all hospital onset COVID cases. And when the reports came back within 5 days, this changed to 20% of cases. And interestingly, over 70% of the IPC teams that were using these data, they reported that sequence data increased their confidence of outbreak assessments. So why this matters? Well, this operational data directly fed into the paper we're going to talk about on health economic evaluation. And so if sequencing changes IPC behavior, we know that has cost implications, both positive and negative. From a positive point of view, we could be avoiding unnecessary ward closures, targeted cleaning, fewer wasted staff hours. Clearly, there's negative aspects of the cost as well, these extra isolation or testing when new transmission links are found. And this was a way to try and quantify that balance. So why do we need to assess costs? Well, sequencing isn't free. It requires staff time, requires consumables, equipment, training. And so in any resource-constrained system, which will resonate with, I'm sure, many people working in the NHS, we have to justify not only whether something works, but whether it's a sensible use of our limited funds. And so the health economic evaluation provides a framework to do that by comparing the costs and the consequences of the intervention against standard practice. And for IPC, I'd argue that this evidence is often missing. And so this paper, like a few others, starts to fill that gap. So I thought this is an economics paper. I'm not a health economist, but I thought it would be useful to touch on a few approaches and terms that are used, which might help us sort of understand things. So there's a few concepts that are used within this paper and provides the model which has been used. And I've put the reference at the bottom there. The first is around perspective. And so when economists talk about perspective, this is about who pays and who benefits. So in this study, this perspective is that of the hospital trust. So it includes only the costs that the hospital incurs, the staff time, consumables, ward closures. It doesn't cover broader NHS or societal costs, such as patient outcomes, long-term disability, or public health benefits. So it's important that when we're talking about when we read that sequencing, for example, is cost neutral, it's about cost neutrality to a hospital budget, not to society as a whole. Now, incremental costs is the next concept. So every economic evaluation needs a comparator. And so the key question here is what happens if we add sequencing on top of existing IPC practice? So we're not asking whether whole genome sequence is expensive in absolute terms, but whether it adds or saves money compared to what we're already doing. So the incremental framing helps kind of avoid the trap of some saying it's expensive without recognizing what it replaces or prevents. One strength to this particular study, which I find is the use of micro costing. And so instead of averaging or estimating the costs of individuals, the group itemize every input. So this means that timing of lab staff, counting pipette tips, counting the flow cells that you use in genomics, and calculating depreciation on sequencing machines. It's all inputted here. So it's building up from the ground how to get these totals. And I think that's important for sequencing pathways in hospitals, because a top-down averaging approach is likely to be too crude, particularly when aspects around at different hospitals varies. And so anyone that's interested in looking at this, the supplementary tables in the paper are very detailed, so it's very transparent about what's going on. The fourth aspect is around opportunity cost, the trade-offs. In this sort of the principle is probably, I'd argue, what most people underestimate. The opportunity cost is what we give up by spending money or time on one activity instead of another. So if we fund a sequencing service, we might have to spend less on our surveillance nurses, our environmental screening, our staff training. And so the economic evaluation helps make that trade-off explicit, ensure we invest in where the greatest benefit is. And so it's about prioritizing wisely. And the final bit to this is around a sensitivity analysis. So no cost estimation is perfect, right? Prices fluctuate, batch sizes of sequences vary, turnaround times can slip. So the sequencing analysis deliberately tweaks those assumptions to see whether the conclusions change. And so whether you double something or halve something, reagent prices, you can still see whether things have approached. And we'll come on to talk about that. I recognise I spent a bit of time talking about that, but this is a complex topic, and it's just to try and sort of set the scene. So the authors captured the cost in two main ways. First was around sequencing pipeline, and you can see here I've listed the various aspects of sequencing that were being used. This was lab staff, consumables, equipment, depreciation, and the training to use to interpret the sequencing reporting tool. And then secondly, they looked at the IPC activities, the isolation, PPE, cleaning, all the bits that we're used to, but also included ward closures and the numerous outbreak meetings that we're all undertaking. And they used interviews, activity logs, and price listing to capture all of these. And as I said, the supplementary data really gives an incredibly detailed idea of what was being captured. So let's get to the crux of it. What was the costs and what was actually found? So as we go through things, so if we start with the sequencing costs, what the team calculated is that the average cost per sequence, and this was including everything, this wasn't just the manufacturer's cost of what they example, was that it cost about £77 per sequence in the rapid phase. And this interestingly reduced by about £10 in the longer turnaround phase. And this decrease in cost was entirely explained by the batch size. And what that means is that when you rush the samples through within 48 hours in the rapid phase, you can't fill all of the sequencing runs. You can't fill up to maximum capacity. So the consumables and the staff time get spread over fewer samples. So during the longer phase, the batch sampling improved and the sample cost went down. And if we break this down a little bit further, what's interesting is it was the consumables in sequencing that drove the total cost. These were about 2/3 of the cases. Staff time was about 20%, and depreciation and overheads made up the rest. So interestingly, the price of sequencing isn't primarily labor or machinery, it's the reagents that we were using. And I think that's useful because consumables are where I would think a lot of the economies of scale could make the biggest difference, and perhaps that's something we can chat about later. When the team looked at the IPC costs, these were the IPC costs across 14 sites, across the 14 sites involved across a 3-month period. And the authors tailored all of the resources used, and they looked at both the hospital-associated infection management costs and the outbreak costs. And you can see here that across the study period, across the sites, the management costs came to nearly £250,000, and this was isolation, cleaning, screening, contact tracing. Fascinatingly, the outbreak management costs were roughly double that. The ward closures accounted for nearly half of these outbreak costs, reflecting just the cost of lost bed days. And I suppose you can imagine the outbreak meetings themselves are expensive when you take into account the senior clinicians and managements that were coming to them and spending their time there. So it's reflecting a kind of broader disruption on top of these things. And I think these findings are striking because they pinpoint where most of our IC budget was going to, and it wasn't necessarily the investigations themselves, but it was these secondary consequences and organizational disruption. And so together, the two categories accounted for about £640,000 on COVID-related IPC activity across the 14 sites over 3 months. And so if we do a bit of a back of the packet calculations on putting this into context, each site, and I think I read this in the paper correctly, sequenced about 100 samples each per the over the 3 months. And so if we take the highest figure of the sequencing of £77, and we look at the 14,000 samples at £77, you can see that the sequencing cost just over £100,000 over the 3 months. So I just want to take that point to pause and see that. So the sequencing costs over the time period cost £100,000. The IPC management costs over that time cost £640,000. So when people ask, is sequencing expensive? I think we really need to answer that depending on what you're comparing it to. And many might argue from this that actually the sequencing costs are certainly a lot less. So what difference did this make? And the authors were trying to link the sequencing activity to the change in IPC behaviors and the resulting shifts in cost. And there's a logic to this. So the Hoki study, which it was looking at, was a natural comparison. First we had how IPC was managing things without sequencing. That was the baseline phase, and then how things were being managed with the sequencing report. And so by comparing those periods, the authors could estimate how the introduction of sequencing might affect both the number of infection control actions and their associated costs. And so this reflects the incremental costs of sequencing that we were talking about compared to standard practice. So the additional money saved or spent. And so in this, the sequencing had two competing economic consequences. The first was the additional cost from detecting new true outbreaks. So when sequencing confirmed that transmission had in fact occurred and that multiple cases were genetically linked, the IPC teams sometimes intensified their infection control measures, added in cleaning, or additional cleaning, isolation, testing. And those additional actions had a measurable cost. And we found that about £5,000 of additional expenditure. Conversely, the cost savings from ruling out incorrectly identified or false outbreaks, so this opposite scenario when actually the sequencing showed that cases weren't related. In those situations, IPC teams could stand down outbreak responses earlier, avoid unnecessary ward closures, and reduce staff time. And interestingly, avoiding those actions generated a saving of about £11,000. So the net balance of these two effects was a slight favour towards cost saving, so £6,000. And it might seem particularly underwhelming, right, that £6,000, not a massive, huge saving. But I would emphasize that for IPC interventions, this kind of, I suppose it would hit more of a cost neutrality, is actually quite a good result. Remember that most infection control measures that we add cost to prevent downstream harm. And so here, the sequencing added this precision, but without increasing the total expenditure. So it starts to build a case for sustainability. It's an intervention which improves our understanding and decision quality without costing any more. And I think the impact, is clear to say, though, that it was heavily dependent on turnaround time and local integration, so that when sequencing reports were returned within 5 days, the IPC teams were able to change their management in about 20% of cases. When the reports came a bit later, the impact dropped sharply. And so it was often too late to inform on ward-based decision changing. So I think the cost benefit hinges on speed. And the faster the feedback, the more likely sequencing is to prevent unnecessary actions. just to touch upon what I think again was another important another important part of this study is the sensitivity analysis. So the authors ran this and testing alternative assumptions to sequencing cost, batch sizes, staff timing. And this was to really check what the overall message was and if it held steady. And under most realistic scenarios, the whole genome sequencing remained approximately cost neutral. Under the best conditions, it moved to a cost saving. Under the worst conditions, it became slightly cost increased. But it suggests that it's not just the technology that determines the value, but the logistics of it. And this kind of rapid turnaround and proper integration makes the difference between breaking even and overspending. So overall, I think the financial story here is interesting. It's balanced. I think if sequencing added roughly 77 pounds per sample to lab costs, but often saved more than that by preventing unnecessary outbreaks. And so when delivered speedily, rapidly, and used well, it feels like it could be effectively cost neutral. So we need to think about the strength and the limitations of this, right? I thought that the micro costing, this kind of level, was a real strength to the paper, this granularity to give kind of credibility to the results. We saw it across a diverse set of settings, making the data arguably more representative than single sites. But we do need to recognize that this variation or adding in variation does add additional noise to interpreting data. It was conducted in the midst of a pandemic, right, which I think is impressive in itself. The supplementary data is really transparent and open in terms of what's going on. And I think the sensitivity analysis really showcased that the robustness of the results, that is not changing in extremes of circumstance. Now, clearly, there's a lot of caveats to this. The study was conducted in extraordinary circumstances. Hospitals were stretched, staff absence was high. This was the alpha variant at the time. So costs may not be generalizable to hospitals in steady state, other pathogens. It's important to recognize that as we were, again, all familiar with guidance and testing strategies was changing repeatedly. So some sites were updating these during the study. Again, the analysis didn't include certain factors, occupational health impact, staff sickness, redeployment, and we know that staff sickness was particularly high and those costs weren't necessarily captured. And they were likely to increase the burden of outbreaks. But in turn, if this is increasing the cost of outbreaks in IPC, it's likely to make the cost of whole genome sequencing that bit more effective. So it might be just actually even understating the savings. The evaluation window is 3 months, right? So and we can only infer on that, and it might be that it was too soon to miss even larger, less frequent outbreaks that were more costly. And so you do wonder whether modelling over the year and where economies of scale and learning processes were coming in might have adjusted the results. And you'll see from the paper as well, it was missing patient level outcomes, which would have been interesting, and other tangible benefits like the confidence to staff, patient safety, and reputation, which are not easily monitorized, but important. So what does this mean for IPC? Well, I think even when this doesn't show a reduction in rates, certainly whole genome sequencing in this instance gave IPC teams a greater situational awareness. And I think that's had two major operational benefits: that we saw targeted action. If sequencing confirmed a link, we could focus on cleaning, isolation, and screening where it's most needed. And it also supported confidence to stand down. If high resolution sequencing showed key cases weren't linked, then we felt we could safely be able to step things down, open bays sooner. But it's important, I think, that sequencing doesn't replace epidemiology, but it helps sharpen and strengthen it, giving this level of confidence to act decisively. I think from a hospital management perspective, the cost neutrality, being cost neutral, is actually a positive outcome. As I've alluded to, IPC interventions cost money, but we accept those costs because we want to prevent harm. But actually, if we can add value and precision without increasing overall expenditure and do it within existing budgets, that's got to be attractive. I think the the economic and the operational value doesn't come from the sequencing machine itself. It comes from how they're used, and that's been really clear. And I think the study shows that the timeliness and the interpretation of the reporting tool is pivotal into making things usable for IPC teams. So for the IPC leads thinking about applying this locally, the priority shouldn't be just about getting the sequencing done, but it's about how we get the results to our IPC huddles, what format we see and how we can use it. So it's about clear data pathways between the lab, the bioinformatic interpretation, down to the IPC service. It's about staff being trained to interpret these genomic relationships. And it's about establishing the escalation process, the governance around this. If this report says likely transmission, what do we do next and quickly? And so it's without this integration, the sequencing risks becoming a kind of retrospective audit tool rather than a live decision support system. So I think this study hints at the sort of subtle but important shift on how IPC decisions might be made. We've traditionally relied on experts and circumstantial evidence, but I think we're now seeing a new type of, with genomic data, maybe introducing a new type of objectivity, how it can confirm and challenge our assumptions. And I recognize, this is going to feel uncomfortable, as all new technology it is. But I think ultimately, if it strengthens IPC credibility and trust, and over time, as we do with other things, we'll see how it could change outbreaks. In terms of the future, well, this study was COVID specific, but I think the principles are transferable. I think we need to see how this is transferred to other healthcare associated pathogens and maybe into the environment as well, and these kind of mysterious transmission events that we tend to see, that particularly we identify through genomic surveillance. So I suppose my take-home messages from this were that I thought that the paper is methodologically a very good approach to health economics from a non-health economics expert. They were very transparent, it was pragmatic, and it was conducted under immense pressures. I think it demonstrated that the implementation of rapid sequencing for IPC is financially feasible and operationally instructive, but we do need to be cautious about how we interpret these beyond the current setting. But I think it does provide a nice platform for future work. These are my references, which we can share, and I've shown you one already. What I will do now is stop sharing my screen and hopefully come back on with Phil.
Thank you, James. I really enjoyed that. A really good kind of understanding of the paper and the methods behind it, and then kind of the implications for IPC as well. So please use the Q&A to get your questions in for James. James, we've got one already, which comes from David, asking about, essentially, with this being conducted during the COVID pandemic, and you kind of alluded to how much challenge there was on the health service at that time. I don't think I saw it, but within the paper, was there any discussion around how this might look if that pressure wasn't there? In terms of how could it be even more cost effective or even more successful?
Yeah, good point. And I suppose that's clearly the key question. So there was a lot. So they were the paper was transparent about the limitations and the setting and being really clear about that. They did align to the fact that actually there are ways that this might be translatable, and it's the principles of translation. But we're in a very different state now. Let's see what happens in a couple of months as we go into winter, and it's not just COVID. But I think it leaves a really big gap, and I tried to allude to some of the ways in which if things change, it might change the actual finances. But I think the challenge is it's really difficult, and health economic analysis and these type of approaches are difficult. There's a number of other health economic analyses out there that look at sequencing in various ways, not just around COVID, and they vary in terms of macroscopic level, in terms of national savings. They look at there's loads of different analysis techniques. So and there's some ways in terms of patient outcomes and DALYs and bits like that. So I think it's more of a platform. I think they make some inferences. Sorry, to answer your question, they make some inferences. I'm good at just going off on one, so sorry, just rein me in. But I think they were very appropriately cautious about generalizability because of such unique setting.
Yeah. Okay, I understand that, and I guess, like you alluded to, there'll be more data coming, won't there? And I think we're seeing more and more now around the advent of of whole genome sequencing for kind of these types of analysis. So it'd be interesting to see some comparative studies. No doubt there'll be a kind of meta-analysis coming soon, or some kind of systematic review. Um, there's a question here from Karine, which is a really good one, actually. How do you evaluate the cost of not implementing extra IPC measures to avoid or reduce outbreak? That is a good question.
That is a good question. Thank you, Karine, because it's really difficult. As I said, I think it's one of the challenges we have in IPC when we're trying to do research or show kind of impact. How do you measure the impact of absence or absence of infections or absence of intervention? And I suppose the way this was done is in terms of sort of stepwise approaches, that kind of intervention or sort of timed intervention. And then what they didn't do is then revert back to baseline as well and measure that. I think it's really difficult. I don't think I'm the expert to ask about this, but I think one of the things that I think is fascinating, and just to talk separately, in Sussex, we've been using sequencing as part of practice and doing a project around that. And you start with people sort of cautiously sort of approaching what the results might mean. You put it in for a period of time. Now people are asking for the results and they want them back. So I think parallel to all of this is around behavior and utilization and bits like that. So I think one thing that I would find fascinating is the next step to this project is how IPC teams found it once the IPC intervention was withdrawn and then they had to go back to standard practice, right? Because it was showing loads of different things. And we see that for not just COVID, but others. You pick up the kind of incidentals, you rule out with probably quite a high degree of accuracy the transmissions which you were convinced were transmissions. And so, I think, I'm sorry, I don't have an answer to that question, but maybe soon.
It is a tough one to answer, but I thought you made a really good attempt. Just building on that, and this is my own question, I guess, but it's just something that's kind of pinged a thought in my mind. Do you think that whole genome sequencing has got the potential to make us think quite differently about IPC? Because I think when we think about IPC traditionally, I think we all think about it as we know we've got a problem, we've got to do something about it now. So we're kind of being reactive. Do you think that whole genome sequencing can actually make us think a lot more proactively because we're kind of maybe, as you've alluded to, detecting these outbreaks or kind of looking at the risk of outbreaks developing because we know more about, these organisms and their transmission? So do you think this might give us a bit of a shift in the way that IPC kind of exists?
Yeah, really interesting question. Something that I've been trying to think about, in my general life. I think there's probably a few elements to that. Firstly, there's a variety of different ways you can use genomics. So you can do it either reactively, like we might do with sort of in current practice, where you take the isolates you think are involved, you sequence them, and it tells you what, gives you an answer. Or it gives you a kind of, there's a yes, the no, and a big grey area in the middle that we need clever people to help us think about. There's the next stage where you sequence everything all the time and you use that to look at outbreaks, and then you start to see other things as well. And so I suppose it's expected that we'd see stuff that we think is happening and we'd have to maybe change our mind about that, and we'd identify things that were unclear, we weren't these cryptic or undetected transmissions. But I think, and a lot of that it's probably going to highlight more questions than answers in terms of, we're thinking a little bit more about community aspects and how we look at the relationship across different healthcare systems. So in terms of how we do it, I think part of it is, again, confidence, and we need to understand what facilitators and barriers are within all of the stakeholders to utilize this. I think part of this, and something that I've been looking at much more, is we have all these results back and you can make a decision, and we see this in our everyday life. We make suggestions and we make recommendations of IPC practice. There's a separate component about whether they are actionable or not, and the amount of people that we want to ideally put inside rooms or cohorts, and it's just not practical. And so how do we do that and move from the control of infections into the prevention of infections? So I think in all honesty, I think we need to move towards an implementation side of it. I think we've got to a point now where the research has told us genomics is, gives this extra level of resolution. We can really unpick what is going on. It's not the be all, we need to complement that with our clinical approach, our epidemiology. It doesn't sit alone. But I think we now need to know how we use it practically, not just in one hospital, but potentially across a system, a healthcare system, and between different systems as well.
Mhm.
So, and we're seeing bits like that with the metagenomics work that's happening. I'll pause because I'm just going on.
It's fascinating insight, and it's one of the reasons why I think it's such an interesting topic because there are so many good examples of what it can do, but it's still kind of what it looks like in practice, isn't it? And it's kind of integrating it into practice. So I've got more questions, James, which is great. I think this is more of a comment from Sharon, one of your colleagues. Thank you, James. Regarding financial economics, NHS budgets work in silo. If whole genome sequencing increases the lab budget but could decrease the clinical budget, it's not always perceived as financially viable despite the patient safety umbrella. I don't know if you want to comment on that.
The only comment I have is why is Sharon not working on that anyway? Um, I'll pay for that later. So I think that you're absolutely right. I mean it's how do we it's fine to do all of these kind of health economics and show this, but we're very aware that we are under a lot of constraints. We know that all of our healthcare systems are focused on short-term expenses versus long-term gain. And how do we take that narrative? How do we influence and change that? And I think so part of it is about really showcasing the health economics, and we need to work with industry around innovating and taking advantage of economies of scale and making things as cost effective as possible. Um, my approach, I think the approach is going to have to be around patient safety, on resilience, on reducing impact on secondary care, all of the ways the NHS strategy is aligning to. And I think we don't know that yet in terms of what is the true impact, again, as I get across the system. So I think there's still some work to do about how we implement it. But I think we're in a really sticky situation. The other thing is how we work with other users of genomics, our cancer services, our genetic services, our pathology services, to make more global use of genomic infrastructure to again make it more cost effective.
Yeah, I really agree with that. And I think the even more cost effectiveness will come with time as we see more and more people implement it. And I think we see more competition in the industry space as well. And I
Yeah.
think that'll drive down the sequencing cost. Okay, one more question we've got time for before we wrap up. David asks, this is a great question. So in Wales, David said that all their C. diff isolates are sequenced. And they think this is the way forward because they're seeing many linked custom clusters, but then they're seeing single cases also increase, which aren't linked. So the question is, should we hold back until we see linked clusters before calling an instant, or just go with increased number where sequencing results shows where single cases were reported?
Yeah, great question. So my thoughts. So I suppose it slightly depends on the question that what you want to achieve. So if you're looking at outbreaks and preventing further transmissions, get it. We're all used to that. I do think the complementary element to sequencing is around the surveillance and understanding new strain epidemiology, new strain
Hmm.
emergence. And so I think it depends on what aspect that is. If we're looking at relatedness between strains, we have the resolution to be able to now identify a transmission at the first transmission, the second time it occurs, and so ideally preventing onward spread. So I think that's one aspect. But as you say, you could find an individual strain. We have the ability not just to look at the relatedness, but to interrogate the genomes to look for nasty genes that are associated with particular virulence factors. And so actually we have a sort of greater than the sum of the parts of using this genomic data to look for these, what we know are virulence factors, and maybe start targeting that. An example, Staph aureus and PVL, there's a whole range of all of these things. But also it helps support the idea, I imagine, would be that if we could do it locally and upload that to UKHSA, build national surveillance, look for emerging pathogens in a more detailed, wider aspect. So yeah, I think there's probably purpose for both aspects, but depending on who you are. But clearly resources are that if we had all the money and all the resource in the world, but perhaps our IPC teams need to evolve in a way that we've got not just the outbreaks, but then we have to respond to emerging pathogens without waiting to kind of be told retrospectively that there's X number of cases in the region. And perhaps that's a part of IPC that we will learn more about and evolve.
Yeah, definitely. I really like what you said there about the virulence factors as well. I think that we see some kind of devastating examples, and whether or not genomics can help unlock and really help us understand the risk of some of these organisms, and particularly these emerging organisms that we weren't talking about. I always think about things like Staph capidus or Candida auris, that we weren't really aware of a couple of years ago, and now they're causing kind of outbreaks or infections in things like neonatals or are vulnerable.
And
James.
if we were being incredibly morbid as well, we have the ability to look for, synthesized bacteria. And if we were looking more about emergence of, bioterror, I'm not suggesting we need to do that, but there are other layers that we can use, and, the potential use of this cumulatively.
Definitely, definitely. And I think we're entering an exciting era in that respect. James, thank you so much for coming on. I'm just going to close with one or two slides. Really enjoyed your talk and your insights, James. So thank you very much from everybody. For those of you who are first time to IPC Partners, just to suggest and show that we have a new website, I'm just going to leave that QR code up there for you just for a couple of seconds, which will take you to our new website, which we're proud of. So you can see our journal club schedule on there, and you can directly register for journal clubs, or you can subscribe to our mailing list if you want to find out when we're putting out a blog or we're talking about a new journal club, for example. And then just really quickly to run you through our next journal clubs. We're delighted to partner again with the Healthcare Infection Society on the 5th of November. So that will be our next journal club. We're partnering with HIS around an AMR special edition. So we'll be looking at some papers around antimicrobial resistance, which ties in really nicely with Antimicrobial Awareness Week, which is in the middle of November. We've got a gap in November, but we will fill something. Probably John and I will do a talk then. And then we've got Alistair coming on in December to talk about a really interesting initiative around education in IPC, and this idea of potentially using things like cartoons to educate our children and adolescents around the role of IPC in prevention of infections, and what that means for us from a behavioural perspective. As you can see all of our previous recordings on our YouTube channel, and please share them with your colleagues. This whole purpose is to be free at the point of use, and to really promote and share IPC knowledge. And I think we're so privileged to have people like James come on and share their expertise, and for you to be able to ask him questions. So James, thanks again. And without further ado, I'm going to close the journal club, and we hope to see you all in a couple of weeks' time. Thanks again, James. Bye, everybody.